Good morning, everyone, and welcome to the ultrasound neck, thyroid, vasculature, and lymph node lecture. My name is Suzanne Dickinson. So these are the session objectives. You can pause this and read over it if you'd like, but let's go ahead and move on. So I'm going to be talking a lot about relational anatomy. If you don't understand the relational anatomy, then you cannot navigate through the body with your probe effectively. You have to understand the layout that's going on inside of the body to be able then to direct your sound beam in the correct direction. So if we look at the common carotid artery, and this is very simplistic because I'm not going to get deeply into the vasculature in the way that your other lectures have. I just want to point out the relational anatomy as we move along, so we're going to be talking about this a lot. This is a side view of the carotid, and as you know, it's going to originate off of the subclavian, and so that's going to be its proximal portion, and then we have a mid portion, and then we have a distal portion where the diameter is much greater than the rest of the length of it, and it's known as the bulb. And right after the bulb, we divide into an external and an internal. So think about this relationally. For arteries, their proximal end is where it begins. And so to get from the proximal end to the distal end of the CCA, you actually have to be moving superiorly on the neck. Now, the vessels of the arteries, or the arteries rather, are going to be thicker walled, they're going to be non-compressible, and you're not going to see any respiratory variation in them, and I'll explain that in a moment. Let's look at the vein in contrast. So we have the vein, and the vein is going to be draining, picking up all of its tributaries and draining towards the heart. And this is the internal jugular, and that's what we're going to stick with for this ultrasound session. Yes, we have the vertebral just as we have that on this side, and we have an external, but we're just going to be concentrating on the internal jugular. Now, veins are going to be thin-walled and compressible, and they are going to have respiratory variation. So what do I mean by respiratory variation? What I mean is that when you are inhaling and exhaling, you are increasing and decreasing the intrathoracic pressure and thereby the central venous pressure. As you increase the pressure, that causes a back stream to the blood, and so the vessel will actually enlarge and then get smaller with exhalation, and so that's no different with the jugular vein. So when you see the jugular vein, it's very compressible, and you can even Valsalva and make it really quite large, impressively large actually. When we look at the front view, now you can see that the relationship is that our CCA is going to be the more medially placed vessel. Now, all the things that I'm telling you along the way, these are typical placements of these vessels, and when we talk about other structures as well, are there variations? Yes, there are, but I'm going to be sticking to that typical configuration that we would expect to see. So just to illustrate what that looks like in terms of compressibility of the vein, this is actually an image of the pop fossa, or rather the popliteal fossa. So this is actually behind the knee. And what we have is a popliteal artery, and we have a popliteal vein. And then when we compress, we can actually compress out the vein. Now, how is this going to look as we are moving along the neck? So we're going to be moving from a more proximal location all the way to the distal location, and I want to show you what that looks like sonographically. And if I put this little box here to represent where I am putting my probe, and we're putting it in a transverse plane, and I'm going to put it at the level of the thyroid gland. So at the level of the thyroid gland, we're at mid CCA, And we are also, because we have the sound beam transverse to the vessels, the sound beam is cutting the vessels through an axial plane. And so remember too that your probe is going to be facing to the right. And the image will give us, since we are cutting the vessels on an axial plane, the vessels should be round, and the CCA, being an artery, is going to be quite rounded and quite sturdy because of those thicker walls, whereas our IJV is going to be more ovoid, and you're going to see a lot of variation in its size depending on how much pressure you're putting on the probe or with the patient's breathing pattern. Now, if we move further up on the neck, where we get to the distal portion of the carotid, and this is where the bulb is, or the sinus, you know that you have some baroreceptors and some chemoreceptors there. And this is where you get an enlargement to that distal end. And this enlargement will display itself. You can see the big difference between the size you saw on the previous slide to the size of the carotid here. The IJV is a little bit more compressed in this particular image, and that's not unusual as you're moving up the neck or superiorly on the neck, although moving distally on the vessel. This is just a lymph node, and we're going to be talking a little more about the lymph node. If you get confused as to which one is which, you can always put color flow and be able to make out which one is the vessel and which one isn't. Now, once we hit the bulb, we know that the very next movement superiorly on the neck is going to go into bifurcation into the ICA and the ECA. So let's go ahead and move our box or our imaginary transducer here, and we're going to go right here where it is bifurcating, or the CCA is bifurcating, and it moves into these two vessels here. Now, typically, because the ICA will taper more gradually than the ECA, so typically your ICA right at the very beginning of these two vessels tends to be larger than the ECA. Also, the ECA tends to be more medially placed. Now, this is a right-sided, these are right-sided vessels. We have trachea over to this side, and so this would be more medially located. This would be more laterally located under the toe of the probe. We have some lymph nodes in here too, doing a little photobomb on us. Now, this is typical, but it isn't always the case, and so you need to be aware of that. And there are times when the ECA even kind of overrides the ICA, which we can use to our advantage if we're trying to get a long axis image of these two vessels. And if you go long on these vessels, you're either going to be over the ICA or over the ECA, that there are a few things that we can do to try to get them both on the image. So here's an example of going long on the vessel. So you pivot on the vessel 90 degrees so that you are pointing to the patient's head. You do not lose your scan plane of anterior surface to posterior surface or superficial to deep, but this side changes because the toe is pointing superiorly towards the head, and then the heel of the probe is pointing towards the feet. So now those vessels which run long in the body will stretch out like a tube. Here is the bulb, and you can see this gradual taper of the ICA here. So how can we tell which one is which? And we can do that with color flow. And we can also do it by looking for branch patterns off the ECA, because remember that the ECA branches because it's feeding the face. So as I told you, there are times when you can position the probe and you have to think it through, knowing that relational anatomy and knowing how you can cast your sound beam into the contents of the body in order to get the image that you want. In this case, we have ICA and ECA labeled here, and the common carotid artery. And then you can see right in here, this is where the bulb is. That was that larger, more flattened area we saw earlier. But how did I know that one was ECA and one was ICA? And when you look at this, yes, this one does look a little larger, but you can't always depend on that. What's going to tee you off on this is going to be this branch off the ECA. So we should not typically see branches off the ICA. Are there congenital variations? Yes, there are, but we're talking about typical configuration, and we're not talking about any kind of collateralization that can come with some sort of disease states. So to differentiate between the ICA and the ECA, I want you to take the time to use color flow and pulse Doppler. When we use color flow and pulse Doppler, we can drop, I call it a gate, we drop this little gate into the vessel, and we can look at the waveform, the pattern of that waveform. And if we look at the ICA, let's think about what the ICA is doing. It's delivering blood to the brain. And so we really don't want high velocity flows or high velocity or high resistance patterns in there. And so if you look at this pattern, we have our upstroke of the systole, and then we have this gradual downstroke of the diastole and a lot of antegrade flow. There's still a considerable amount of flow here. And so this is indicative of a low resistance flow and or high diastolic flow, however term you want to use. And this will allow for blood to move to the brain in a fashion that would not be dangerous to those vessels in the brain. In contrast, if we look at the ICA is feeding the face, and it has a lot of branches coming off immediately. And you have to have a bit of a higher pressure system in there, or high resistance system in there, in order to force that blood up to the vessels that it's feeding. So we have that upstroke. It's a bit of a sharper upstroke. It might even be at a higher velocity than the CCA. This one is under 100. And this one, if we go across, is at 100. But look at the precipitous drop at diastole. Not as much antegrade flow because there's resistance to that forward motion in diastole. So this is how you can tell the difference between an ICA and ECA, and you may want to experiment with that when you get your hands on the probe for the ultrasound session. What kind of vascular pathology are kind of common that we can see, or something that you can take with you clinically? And of course, that would be atherosclerosis. This is going to be strongly related to age. The risk increases with age, and this is going to be one of those causes for stroke in older adults, 50 and above, where the rate begins to increase and increase as the plaque begins to build up. So if we look at our vessel again, where are these plaques going to build up? They're going to build up in a place where there is this changeover into two different vessels. A lot of turbulent flow in here, and because of that turbulent flow, there's a greater chance of a build-up of these atherosclerotic plaques, and they can often build up into the ICA and extend down into the CCA and maybe a little bit into the ECA. You can get blockage in both, but those plaques can break off, or small pieces of it can break off and be responsible for stroke. Now, how does this look on ultrasound? Well, on ultrasound, here we have our ECA, here is our common carotid, and we can't even hardly make out the ICA because of all of these plaques that are in there. So you'll often get some shadowing off of these as well. Color flow is obviously we would want to see if there's any flow around these plaques. We would want to measure the velocities before the plaque and after the plaque. All of those will have a bearing to the vascular surgeon in determining whether there should be an intervention. And so one of the interventions would be an endarterectomy, and what they do is they actually take out the intimal layer and they will pull out this plaque. always being cautious to protect the nerve structures that are in this area. And then they put a graft over the vessel and repair the incision that they make. So again, strongly related to age, and so this can be an etiology for stroke in older adults. Now, carotid dissection is going to be one of your leading causes for stroke in the population under 45 years of age. And this is going to be a pulling away of the intimal layer from the wall. And this can occur in trauma, so a cervical injury like whiplash, but it doesn't even have to be that dramatic an injury. Some of the injuries can be kind of minor that would cause this dissection to occur. And also there can be a genetic predisposition to dissection of the vessels, as in Ehlers-Danlos or Marfan's. And so when we look at it in terms of the vessel, here is the intima that's been pulled away, and this is the false lumen here, and flow should be going through the true lumen in this picture. And what happens is you can have, again, this is an injury, and so with injuries, of course, you can develop some clots in that, and those clots can break off and move up to the brain and cause stroke. Put color flow, some of that blood can get caught up into that false lumen and add some insult to injury to this pulling away. So that's it for the pathology of the vasculature. I want us to switch gears and take a look at another structure. And this is going to be cervical lymph nodes. And you've had a lecture on these cervical lymph nodes. We're going to be concentrating on the deep lymph nodes because we are going to be visualizing the IJV, and there are chains of lymph nodes that run along the IJV. For a sonographer, we tend to call these things lumps and bumps. This is the patient that has come in, felt a bump or lump on their neck, and it could be of different etiologies. For instance, it could be of infectious etiology if the person has had some kind of infection, could be viral, could be bacterial, whatever the case might be. They had some increased size of the lymph node, and they're aware of it, and they look at it. It's not always the case. Sometimes you can feel small little lumps and bumps, and they're just normal lymph nodes. And we'll look on those at ultrasound, and I'll show you what normal ones look like, and I'll show you what reactive ones look like. They are also used for cancer staging. So cancer can metastasize and move through the body through that lymphatic system, and so histology, when a lymph node is resected, histology can look for signs of cancer. Now, again, from our point of view as sonographers working with our radiologist, we are not going to talk about the lymph nodes in terms of that anatomical positioning that you heard in other lectures. We're going to talk about it in terms of levels on the neck. And the pause here for a moment, excuse me.